Welcome to the AIDS 2014 Global Village Connect webinar series. This is a series where we'll explore some of the presentations that have been presented as part of the Global Village seminars, and we'll ask our guests exactly what it was that they covered here at AIDS 2014 in Melbourne, Australia. We also invite you to contribute to the conversation, and you can send your questions to us via the chat feature in the web stream. Now, I'd like to welcome to the program LAUREL SPRAGUE. She is a regional coordinator for the Global Network of People Living with HIV from North America. She's in political science at the Eastern Michigan University, and she serves on the steering committee of the US People Living with HIV Caucus, and is vice president of the board of the project Ending HIV criminalization and fighting stigma and discrimination. She's been on stage recently at a presentation titled Meet the NGO Delegation, the United Nations UNAIDS Programme Coordinating Board. Thank you very much for joining us.
Thank you.
Well, the delegation that works with UNAIDS, tell us about sort of civil society element that UNAIDS takes on board.
Well, UNAIDS is unique among the United Nations organizations in that has civil society formally represented on its governing board. So the governing board is called the Programme Coordinating Board. It's basically a board of directors, like in any, like they used to in our nonprofit organizations. And so the way that this has been set up is that we have 10 members of civil society at a time who sit on the PCB, the governing board, and serve as full board members. We sit to the other members of the board with a slight distinction. So on the governing board are member states of the United Nations, 22 of them at a time. They take turns serving on the board, and there are also representatives of 6 co-sponsor organizations, and those co-sponsor organizations are other organizations within the United Nations body, like the Health Organization, start listing things, the World Food Program, UNICEF, etc., that work together to coordinate their activities related to HIV and AIDS through states. The co-sponsors don't vote. Member states do actually have a vote on the board.
It sounds terribly complex.
I know.
And the question is left then, what all of this toing and froing with all of these relevant parties all wanting to have a say and wanting to have what comes out of it?
It's really been interesting, and I'll start with a caveat. I only joined the formal delegate in January, so part of what I've been doing since January is to just pay really close attention to what difference it makes. I'm constantly asking myself, why are we doing this? Because we're each, for the NGO delegates, we're each spending about 10 hours a week, which is a quarter of our time.
Right. And
we're all from civil society organizations that are perpetually underfunded, and they all do things in countries. So we're trying to balance the kind of good we might be able to do with people at home with taking part in global governance. And so I think there's a constant question trying to make sure that it really is a good use of time. I will say, I believe that the NGO delegation has made a difference in our position on the board. This is something that, as I said, I've been trying to work out over the 6 months that I've been there so far, and I do see that things change because of it. But she just turn back to you and make sure that's actually the question you were asking me.
Well, I often feel that with so many players and a committee so vast, that deals with politics, it deals with civil society, it's going to be all things for all people. And at the end of the day, we want to see the other end that are bringing a difference. And that's the question.
I do think it is. The fact that UNAIDS is there makes a difference, first of all, because it's a space to coordinate what all of the other UN organizations would be doing or are doing, so that we're not duplicating efforts. But also, it's the one place that we have that really is the holder of best practices. And UNAIDS has been able to make some long statements about how gay other men who have sex with men really ought to be treated, how people living with HIV ought to be treated. What are the best practices for people who use drugs? They've made strong statements against criminalization of people who use drugs, criminalization of sex workers, criminalization of people living with HIV. So we've had, I think, a voice for human rights in the HIV epidemic that's been able to compile the evidence that demonstrates that really protecting human rights is a best practice for governments to follow. I think without UNAIDS, we couldn't do that. UNAIDS does, though, to some extent, what their board tells them to do. So you're right, there are so many actors and we have so many agendas on the board. So the even among the civil society delegation, there are 10 of us who come from 10 organizations, and we've really strove, we really strive to make sure that the delegates come from areas of the epidemic. So we're not only regionally diverse, but we have diverse experiences. We work for gender balance. We have generally about half of the delegates are actually living with HIV ourselves. And then I have people who are connected to drug user networks and sex worker networks and other population groups. What to work with, though, are the 22 member states. And the UN system is built on this idea that member states, the individual countries, determine the source of how the United Nations system works, right? And so the fact that we're actually at the table with them means that we have some ability to influence what happens, but certainly working within these broader diplomatic and sometimes not so diplomatic interactions that are between these different states. And so what the United States might want, sometimes very similar to what we want, sometimes very different. So very different to what Switzerland wants, which is sometimes very similar to Australia and sometimes not. And then we've got the African group, which has works together and sometimes have some disagreements among them. And over the last few years, there's been a bit of a group with Egypt and Iran having some specific ideas about what UNAIDS ought to be doing, but often quite at odds with what the NGO delegation has hoped to see.
I think what ultimately has found back in the language as instead of being a pandemic, it's referred to as a global epidemic. Because the nuances in each region are so specific to that region, is very much a localized response to China. When we see political engagement that changes, like we've seen in some of the sub-Saharan African countries, one back laws around homosexuality and key affected population. This United Nations has the most power to step in, particularly, and make a difference. Yet we see very little engagement from most countries interacting with the UN as they push forward to make these changes. Get your perspective on this.
Tricky. I want as advocates and people who human rights and dignity and basic safety of other human beings, especially when they feel close to people who are also gay and lesbian, people who are also transgender, people who are drug users, people who are HIV positive, whole list. What I'd love is to have somebody be able to go in and say, you can't treat people this way. The Universal Declaration of Human Rights, we have covenants, we have treaties, this shouldn't be happening. And then I think where the challenge comes in is that each states are sovereign, and to some extent have the right to determine what happens within their sovereign territory. And to extend to that, the nations or other global institutions try to step in to then also lose a bit of legitimacy. So I think we really need a United Nations system that is seen as very legitimate, and so it's a very difficult rope for them to walk, because if they do step too far, then those countries won't listen to them at all. So I think we're constantly pushing within the UNAIDS program for very strong statements about how people ought to be treated. To reset the bar when these laws happen, and it's, we've seen it in Uganda and Nigeria, but we've seen it outside of Africa as well, and we see what's happening in Crimea, we see what's happening in Russia, we see what's happening around criminalization in North America and the Nordic countries, as well as Australia. So we have these really in situations around human rights that we're really push strong attention to, and yet understanding that, we're as hard as we can, but going to be a bit of a diplomatic path that then folks are going to take.
On AIDS 2014 Global Village Global Next WebEx webinar series is break from the USA. She is part of the NGO Delegation to the United Nations UNAIDS Programme Coordinating Board. And along your particular focus in the US, HIV and AIDS in the US, it's a very sensitively hit out racially. And it doesn't play out racially here, perhaps to the same extent. Here, really, we're very much gay men who have sex with men focused issue regarding HIV. The US is very different. How is the US going to challenge or tackle this particular challenge?
Around the racial disparities that we see. Well, what's really clear in the U.S. is that a group of people that has been marginalized economically and politically or socially,
they're on the list.
They're on the list. They're disproportionately hit with HIV, and it's no coincidence. I mean, I think that there are so many levels of challenge, not in many other countries as well, but certainly in the U.S. People who have really good reason not to trust public health, who have really good reason not to trust the police, historically. So when we are now, so then we get, not just now, but over 30 years, this epidemic comes out. And I think it's really difficult for people to know, trust to get good information. Because historically, these, public health authorities are seen as agents of the government and have acted as agents of the government and not in the best interest of African Americans or Latinos or Native Americans or gay people, poor people in general. And so it's really complicated. Right?
30 years on from this epidemic, taking hold, it's kind of frustrating that we're even having these conversations. And it must be, for someone working so closely in the US in this sector, be infuriating.
Well, it is. But you know what else is infuriating? It's not just HIV, it's that having these issues around racism that result. I mean, and that's more than 30 years, and the issues around poverty. I mean, even in the 60s, we're talking about having, war on poverty and turned into a war on poor people. Or having, a civil rights movement that was really effective, and yet at the same time didn't change any of the underlying economic conditions that shape people's lives, and in many ways kept racial prejudices and racial discriminatory systems in place. So it's ridiculous, but I think I guess it'd be infuriating. But honestly, I believe that we're a struggle. That as soon as we figure out how to address the current struggle, there's going to be another one. It's not like just going to figure out one group of people and we'll all be liberated and everything will be fine. So I guess I think it's all in a day's work. So it's wrong that the story exists, but we're naive to think that overturn these large systems quickly. I think we have to from the grassroots up to make societies that we want to live in.
One of the things that I know that you've been working on as part of your, remit in the US is organisation. Right. We've had here in Australia, and particularly here in this state, Victoria, the host state of AIDS 2014, we have a law that is specific to HIV, and that law has meant that it's said it is moralized, it is targeted, and that reinforces around the issue plays out in all sorts of ways. You recently had a bit of a win in the US.
We're talking about the state of Iowa, which had the harshest law in the entire country. People were being sentenced for consensual sex between adults with no transmission to 25 years in prison and lifetime sex offender registry requirements. The level of injustice is just horrifying. And in Iowa, like many states, it seems to be clear that if a person living with HIV is alleged to have done anything wrong, including not disclosing their HIV status to a partner, whether they did or not, they really haven't had a chance in the court system. So there's been a really terrific movement in Iowa led by people living with HIV and also people living with HIV co-infected with hepatitis. To remove that law, to change and remove that law. They had a champion in the state Senate, Senator Matt McCoy, who listened and took up 20 or 30 statewide groups and went to the political abyss as the representatives in the House of Representatives talked and debated over how they might change the law. And they had to make a lot of sacrifices and negotiations. And what ended up happening is that the law reformed, which is absolutely amazing. They got people off the sex offender list, including retroactively, people coming out of prison, which is remarkable. At the same time, the law isn't perfect, and still everyone's gearing up for the next stage to make sure that people don't continue to be incarcerated unjustly. So the potential for that.
Well, joined here on the AIDS 2014 Global Village. He's now just leading us. John Rock is also on the NGO Delegation to the UNAIDS Programme Coordinating Board. And John is part of the International Treatment Preparedness Coalition with the UNAIDS Programme Coordinating Board. John, thank you very much for joining us today. Yes, John.
Yes, good to be here. Thanks very much.
John, thank you for being a part of this conversation. You've got a particular interest in getting the UNAIDS to take a part in property around diagnostics and medication. Would you talk to us about what it is that intellectual property is being in the way of HIV response?
So going back to the time before patents were pharmaceuticals were part of the World Trade Organization, there was pretty free access, but the World Trade Organization introduced patents on pharmaceuticals, and in so doing it recognized essentially that was going to cause some problems in developing countries in terms of affordability. So in so doing, they introduced something that was called TRIPS flexibilities. What that allowed was countries to issue compulsory licenses for essential medicines and effectively to be able to get access to generic copies of these medicines and thus break patents. And there was something called the Doha Declaration, which reaffirmed this right. But since then, what has happened is that many of the developed countries with pharmaceutical lobbyists have included in their free trade agreements a number of what are called TRIPS Plus clauses, which basically take away those rights. So effectively, the United States, the European Union, Switzerland and Japan are the main people who have intellectual property around patents of pharmaceuticals, and they are the ones that are introducing these plus clauses at the moment. Australia is in the middle of negotiations on the Trans-Pacific Partnership, which is said to be the free trade agreement to end all free trade agreements, and there has been some discussion in Australia about this. It's been going on for a number of years. It involves the United States, which is the net exporter of intellectual property and the one leading these plus clauses. And the other people are Canada, Mexico, Peru, Chile, New Zealand, Australia, Brunei, Singapore, Malaysia, and Vietnam. So what happens basically as a result of these free trade agreements is that countries lose the right to issue these compulsory licenses. Now, it's a very, very complex area, and there are other barriers as well. But suffice it to say that the fine regimens generally are off patent, except for some of the better line regimens, and that's why they're inexpensive. Have been available in generic form, and partly historically this was because the Indian generic companies, and Cipla in particular, the prices down in about 2000. Since then, a lot of these have come off patent anyway, but the difficulty is that the best first-line regimens, which have got less side effects and are more robust, are on patent in a lot of countries, and the second and third line are on patent in virtually all countries, those who are signatories to the World Trade Organization. So we end up with a situation whereby no matter how adherent people are, some will need to go on to second and third line. And for those people who aren't adherent for whatever reasons, and it's very easy to condemn people who are not adherent, but actually it happens in a social context and that's quite complex, are going to need to move to second and third line. And so the matter is that these drugs are very important. There have been a number of attempts to try to address this through voluntary licenses, which have tended to favour the least developed countries, but put pressure on the middle-income countries.
I guess my question is, what on earth can the United Nations do in this space, and what is it you're, as part of the NGO delegation working with them, what is it that you're pushing to do?
Well, let me say, it's not just HIV drugs and diagnostics, should I say, because diagnostics are a very important in
managing breast cancer and all sorts of
exactly. So it's non-communicable diseases, it's diabetes, it's heart disease, it's cancers, it's hepatitis C, it's TB. It's
just genetic coding and things as well, isn't it?
That's another issue as well. Right, yes, yeah. on top of the problems. So in a sense, the spirit of the problem that the World Trade Organization recognised has not been upheld by these countries negotiating these free trade agreements. And we've probably got to the stage where we could try to stop more free trade agreements, and that can be done perhaps in terms of countries considering very carefully their patent law and the criteria of patentability. I mean, we see that Argentina changed its patent law a year or so ago. We see that South Africa is thinking about changing it. India has very high criteria of patentability, which is why the generic industry was able to thrive. So there are things that can be done there. There can be advocacy around opposition to free trade agreements, but fundamentally what I think is required is that we need a different paradigm. And
it's interesting you say that India has a higher level of criteria. India, by Western countries, and I use that term generically, the US, Australia, was criticised as being open, free for open slather. You're saying they had a higher level of criteria for them to protect the patent.
No, to get the patent.
Right, okay.
So in other words, let's say for the sake of argument, you decide that you want to make a tablet form of something that was available as a capsule. The Indian would say there's nothing new in doing that. Everybody knows that tablets can be made instead of capsules, or they would have a look at a particular molecule and say, fundamentally this is the same molecule, all you've done is to tweak this, or all you've done is to make it bioavailable. Basically it's much harder to get a patent in India. And in fact, we see that there's a huge issue a few years ago where Novartis had applied for the patent of Gleevec, a breast cancer drug, and it was used in India, and Novartis went as far as it could through the court system in India to try to show that the Indian patent law was unconstitutional, and they failed.
Yes, it's demonised by countries like America and Australia, a system, but you're saying it's a better system.
Well, I'm not sure it's demonised by Australia. Certainly it's demonised by the United States. But on the other hand, the United States is a net exporter of intellectual property, and it has an absolutely huge pharmaceutical lobby. And they're very rich as well.
So, coming back to the question of the United Nations,
so what could UNAIDS do? Well, I mean, I think that UNAIDS can lead a dialogue about whether the current system is indeed serving the interests of world health. And it's not just UNAIDS, but I think that when we see the SDGs playing out after 2015, then access to medicines for a variety of health conditions are going to be important. But I think that UNAIDS is able to take a leadership position in this. So the NGO delegation, bearing in mind, of course, that in the final event, it's member states who are members of the World Trade Organization and who would vote on issues around a different paradigm. We would hope that UNAIDS might work in creating awareness amongst the member states of what some of the options are and what some of the issues are. I mean, the trouble is that community is well funded to be able to create this awareness, and it's a very complex area. Yet the pharmaceutical industry, of course, has very large resources at its disposal to fight such things.
Our guests are LAUREL SPRAGUE from the US and John Rock from Sydney, Australia. We are talking about the NGO delegation to UNAIDS and the Programme Coordinating Board. You are on Global Village Connect webinar series for AIDS 2014. My name is Dean Beck. John, ultimately, if these patents, they are about companies making money, those companies then introduce the latest technology, they have the latest breakthroughs, they can invest in perhaps the cure. How are they supposed to be able to invest in these developing issues and developing technologies if we're paying our way for them?
Well, again, if you're going to have a look at a different paradigm for intellectual property, then you've also perhaps got to look at a different paradigm as to how you pay for research. However, let me say that a lot of the drugs that are used in treating HIV at the moment were actually not completely developed by the pharmaceutical industry itself. I mean, the classic one, of course, is AZT, which was developed as a liver cancer drug. And there are many other examples where the molecule was developed somewhere else, or it was developed. There was one that was developed by NIH in the United States. And
also been, I guess, the flow on too that whatever they've developed, if HIV being the focus, realise it doesn't work, but it might work for something else, and they've been able to profit from that too.
Eventually, but I think the other issue is that the pharmaceutical industry has talked about the huge amount of money that it costs to bring something to market, but actually that has never been tabled in a way which it can be verified.
Right. Good argument on the surface, but show us the figures.
Well, that's right. That's right.
Well, this plays out in all sorts of ways for people who are living with HIV. Ultimately, it's about access to medication and treatment, and access and compliance are two of the most vital things if we are to stop the transference of HIV. We were talking earlier about what plays out racially in the US, but also in the US, the health system itself, will costly exercise. It's about how you get treatment to people that need it when it costs so much to have a day in hospital.
As you know, we're in a transition period with the Affordable Care Act. Well, long ways to go. And what we do have are people who have health insurance now. When there is such a large portion of our country that has not had health insurance or any guarantee of health insurance. So I think we will see changes. We certainly saw changes in Massachusetts, which is really the model for the Affordable Care Act that we have now nationwide. But the way that the Affordable Care Act was ultimately negotiated, now that we still all get our care through private insurers. We all get insured through private insurers, and then we get our care, it's all managed through private companies, which hasn't brought the cost down. at all. There's no single payer system. There's no ability to negotiate prices.
Someone's paying the bills.
Right. Us. Yeah. It's more or less, we find, basically the costs are passed on to the citizens and the people in the United States. So it is difficult. HIV have long had a separate route for accessing care. So getting care with the same doctors in the same hospitals. But we've had a federal program that gets channeled through the states called the Ryan White Care Act. So we get white money, federal dollars that are used to help cover the cost of treatment for people living with HIV and care for people living with HIV. And a lot of us get some kind of support through the Ryan White Care Act. So it goes to help pay drug costs, the cost of medications. That sure, even when you have insurance, often the kinds of copays that we face make it completely unaffordable to still have medications. The copays can make it completely affordable to go see a doctor. Now we have this that we're always hoping will be reauthorized and maintained, strengthened, in fact, to cover the gap between our insurance will cover and what actually the cost of treatment care is.
John Rock, it's one thing for us to be having this conversation in wealthy countries like Australia and the US, but the UNAIDS has to look at a global issue around medications and treatments, and I guess intellectual property gets in the way of countries that are much poorer than our own.
Well, this is right. I mean, we pay large amounts of money in Australia, but on the other hand, we're a relatively wealthy country. I mean, I thank the Australian taxpayer for funding $30,000 towards my own medication costs. It's very kind of them. But the real issue is in developing countries. In the low-income countries, there have been deals on pricing that have been cut, which have helped somewhat. It has been an awful lot harder to get deals on pricing in middle-income countries, and one suspects, or one might if one was cynical, that the pharmaceutical industry would write off the low-income countries as not being able to afford the prices that they would like to charge, whereas if they squeeze the middle-income countries, perhaps they are. The point that we always make is that access to sustainable, affordable, good, effective medication should be a right for everybody wherever they live, and it shouldn't depend either on the GDP per capita of the country in which you happen to live, or just by geography where you're situated.
Well, let's get a little controversial. Right be afforded to people who slip up, and that right be afforded to people who are negative. And by that I'm talking about pre- and post-exposure prophylaxis. The cost of that to government.
Look, let me take the second one first, the pre-exposure prophylaxis. I think that you have to look at that on its merits. So, for example, a sex worker who may have difficulty in negotiating sex with a client would fall perhaps in a different category to a man having sex with other men who just doesn't like condoms and has a lot of sexual encounters. Yes, indeed, and I think there would be a lot of countries who would be wondering about that.
So who makes that value?
Well, what I would say is that in any case, whilst there are people who are living with HIV who can't get access to treatment, the morality of giving it to people who are not sick has to be questioned. So you're not going to get an argument from me on that.
Okay.
A lot of my positive colleagues may think differently, so I'm expressing a personal view.
I understand that. Laurel, what's your point on this? Surely experience of HIV longer term is going to be better for health systems and outcomes for individuals than the Russian roulette yeah.
Well, absolutely. I mean, one of the things that makes me absolutely enraged, I have to say, is that we have no global triage system for making sure that all the people who need medication can get it. I think that, it's just absolutely frustrating that we have extra medication for anyone who needs it and can pay for it in wealthy countries, and that we don't have enough to just keep people alive, that people are getting tested with CD4s of 50, under 200, and there's a whole other reasons for why people aren't being tested sooner, but then we're not making available treatment that people need just to survive. And John and I are both people who have been very close to death and are only alive now because treatments came out and we, some by some good fortune, happened to scratch our way through until those medications showed up. And so, dying doesn't look any different now than it did, 20-some years ago. Nobody wants to leave their children, nobody wants to go through that, especially when medications are available. So that's, the first thing is, it just frustrates me to no end that we cannot make medication available, or that we have not made medication available to just keep people alive. Having said that, we are going to have medication, have the ability to make it available. The price point that we see now is absolutely false in terms of it actually costs to research and manufacture these drugs. So in some ways, we're getting this artificial.
You would say that. Let's put on the head of the pharmaceutical company. They would say, it's cost a fortune, as John said, and we can talk about show us your books. Right. But then they would also say, if you want us to invest in the latest and the greatest, we need to be able to pay that.
Well, I think we'd believe them better if they didn't make the kind of exorbitant sales they make, if they didn't have the kind of buses, the kind of PR. I think it's really hard to believe their claim when you see sort of the lavish lifestyle payments, et cetera, that happen there.
That's paying in part for this conference that we are currently at this very moment. Right. So, is that part of their, is that guilt money? What is that?
I don't really care. Honestly, I'm so sorry. That's not the question I really care to answer, because I don't know what's in their heart. Sure. I will say I'm extremely grateful that people, for the motivation they had, got their brains to in the right space in the right time and came up with medications to keep people alive. And I don't want that to stop. I'm not against innovation. I'm not against research. I'm not against even making a profit. What I'm against is setting the price point so high that we're having these fights about who ought to be able to stay alive and who's expendable. And that's a real ethical challenge that the pharmaceutical industry has not, for the most part, been willing to face up to. This capitalist model has seen, it's been held up as, essentially the right way to do things without ever really having these kinds of conversations.
There has, John, been a shift in, let's be clear, they were forced to do so, but in pharmaceutical companies lowering prices to certain countries to ensure that they did have access. But this global triage idea, which I love that term, that Laurel has suggested, it's implemented, and there are countries that do not have access, and people are continuing to die. How to change that?
Well, this is exactly what we're trying to investigate. And let me say, to go back to an earlier point, of course, big pharma, as we call them, need to be involved in getting sustainable, affordable, effective medicines to people. It's going to require a lot of cooperation, but the system that we have at the moment isn't really serving us. This is the problem. How do we address the question of affordable medicines? Well, I think that we have to have a dialogue. I mean, there have been recommendations that we need to look at a different paradigm. I think we should look at a different paradigm. Do have different ideas of what that might be. The fact of the matter is that at the moment it's not working, and the issue is that return on investment is fine, and that's one lens that you look through a product, but we're not talking about washing machines, because there's another lens that you can look through which says, this is the difference between me living and dying. So there's also, I guess, quantifying the loss, the cost of the loss, but and if you want to talk about intellectual property, let's talk about that. The benefit we've lost and the inspiration we've lost. It's you can't put a price on that, surely. Well, I think the other thing about it is that giving treatment to people is important, first of all, because it avoids them falling out of the work system, keeps them productive, they pay taxes, they are not a burden to the healthcare system, and we know that if you get people onto treatment, it reduces their infectiousness. So there's a very good cost-benefit argument to both the individual and to society.
Yeah.
Well, this is something that maybe has to be done with a global body, which is why, hello, we're back again with the UN, we're back again with UNAIDS. No question.
So I guess, John, you've been working with the delegation to the UNAIDS for quite some time, I believe. To keep the sector quiet, and how much of it is actually UNAIDS doing what the NGO delegation are pushing for? How much to listen is the question.
Look, they do listen. There's no doubt that they listen. But you know, in a body like the UN, where you have member states who basically make up the UN, things aren't always as straightforward as going out and doing it if you're running a large corporation. So you have to recognise that you're working with a diversity of nations with all sorts of different perspectives on it.
Does that become frustrating from your point of view, who's contributing to this?
Sometimes it can be very frustrating and very challenging. But you know, I think that UNAIDS is the only body that can influence what happens in a global sense. It is a global forum. We have sitting around the table countries from all regions of the world, and I think that they are the best mechanism to be able to do this, and I think that we have to work with them to be able to try to reach those goals.
For this session to a close, I'd like to get from both of you your thoughts on AIDS 2014, your experience thus far. It's really only getting going, but LAUREL SPRAGUE, tell us, you've been to some of these before. How's AIDS 2014 shaping up for you?
I think it was a whirlwind, which I think is the case for most of us. It's hard to have a sense, I think, until about 2 weeks after the conference to figure out what really happens. I think it's really marked by the deaths of colleagues that were en route when they were shot down. I think the suffering of people in Ukraine really was brought home, as well as our own losses. I think every one of these conferences remind me again of people who are gone, as you just said, I think so well. What we've lost in terms of the brilliance and commitment and ideas and innovation and just love. The generation of gay men that we don't have, that would have been mentoring so many young people. All of that comes home. What I think is really interesting to me, and it affects the kind of work I do, one is the Indigenous presence here. I think that the Indigenous Networking Zone has an incredible program, and they've done just a lot of work to bring the issues of Indigenous people related to HIV and make them more visible. It's a group that's persistently invisible and really deserves the kind of attention that they've had to fight for. The other thing that, from a social justice lens, is to me is the focus on criminalization within communities. That we really are seeing broad movements from multiple countries and regions in the world coming together to figure out how we can protect one another and fight these unjust laws. So I think that is something that's really a movement that's starting to boil and move forward, and it's going to be really pick up steam here and then taking off further.
For us to be hosting AIDS 2014 here in Australia, it's a tremendous privilege. Tell us what you hope that will be the lasting legacy for our nation to be the host of this conference.
Even my choice.
Tell us why.
Because it's too expensive to get here, and question the value of having AIDS conferences every 2 years. What affects the lives of people living with HIV is what their governments do, the extent to which they're prepared to step up to the extent to which they're prepared to change laws, the extent to which they're prepared to make a real effort to address stigma and discrimination, the extent to which their country coordinating mechanisms will include treatment and virtually everything.
But it's hard to dismiss the level to which this country has stepped up in the last 6 months. They have moved leaps and bounds to prepare for this conference. Things like waiting a decade for rapid HIV testing is inexcusable, and I have it. That it's got to be the lasting legacy for us as a nation.
Yes, I wouldn't deny that, but I often wonder whether we might not get more use if Tony Abbott were to use his abyss to talk to some of the neighbours who could more usefully follow the Australian model, a bit like Michael Kirby suggested yesterday. Because the final event here, we're preaching to the choir, and it's a very expensive way of preaching to the choir, I think.
John Rock, thank you very much for joining us on this AIDS 2014 Global Village webinar. And to you, Laurel Sprague, good luck with the rest of your AIDS 2014 journey, and thank you very much for joining us today.
Well, thank you very much.
My name is Dean Beck. We hopefully will get you to join us for some of the other webinars that are coming up over the coming days here at AIDS 2014. Thanks for being with us.